Hello everybody. So today's quiz is slightly tricky, though it's straightforward in some ways. You can basically, let's go to the clinical, which is a 45-year-old female with generalized pruritus and itchy plaques on the body since 6 months. Now clinically you're looking at this and thinking this is either Lichen Simplex chronicus, maybe perhaps Lichen planus is a differential. Perhaps something rare like bullous pemphigoid can sometimes present with prurigo-like lesions, so that probably is in your differential as well. But let us see what the histology shows. Now, histology shows a mixture of features. You can see here. This first collage shows essentially quite marked epidermal acanthosis with hyperkeratosis. The hyperkeratosis is largely basket weave, though in some places this is compacted. Now, is this alternating hyperkeratosis and parakeratosis in compact hyperkeratosis and parakeratosis in vertical and horizontal directions? No, it is not really that. Only focally in some places there is compact hyperkeratosis. Parakeratosis is really minimal or absent actually in this case. This is basket weave hyperkeratosis and this is compact hyperkeratosis. In some places you see some compaction. This is expected whenever the epidermis is quite thick, some compaction is expected. Compaction is basically because of compression, because of the compression forces which basically compress the basket weave. What is prominent here is the stratum lucidium, which you don't normally see except in the palms and soles, but because the skin has become so thick, you're able to see the stratum lucidium, which is the translucent layer between the stratum granulosum and the stratum corneum. Now, what else are you seeing? I specifically asked about wedge-shaped hypergranulosis. Now, whenever there is a bit of acanthosis, the granular layer appears slightly thick in the papillations. Now this is sort of, there is some mild papillomatosis. Can you make out the papillomatosis here? These are small papillations of the epidermis. Now whenever there's papillations, wherever there's a dip, you see this sort of prominence of the granular layer. So this is a sort of a wedge-shaped hypergranulosis. But yeah, if you've marked that, yes, I've given you a mark there because this, though wedge-shaped hypergranulosis is not specific for lichen planus, you can see sort of wedge-shaped hypergranulosis in normal skin as well when it's quite markedly thickened. And some of the questions here are trick questions for you. So what do you see on higher power? On higher power, you see that spongiosis is fairly minimal. You're not really seeing much in the way of spongiosis. The basal layer appears fairly intact in this particular picture, but if right at this corner, you're seeing the basal layer damage is slightly there. Now this is fairly minimal. Just because you're seeing focal basal layer damage, you don't call this a vacuolar interface dermatitis. Okay. Now if you look at the majority of the epidermis, only focally in one small place there is a bit of interface dermatitis, but in general overall this is a non-inflammatory, or in fact most of the inflammation, the epidermis is really non-inflamed. The basal layer is not affected. What you're seeing is prominent inflammation in the dermis, both the upper and mid dermis, and you're seeing this dilated capillaries. Now I asked the question, are there any papillary dermal dilated capillary loops? Now this specifically points out to the existence of something like psoriasis, which is absent here. This is not psoriasis, though there is psoriasiform hyperplasia. Now you may call this psoriasiform, though it's quite irregular. In the true sense, we use the term psoriasiform when there is elongation of retirages like this, but they are regularly elongated. These are quite irregularly elongated. So this is not true psoriasiform hyperplasia, though some people may call this irregular psoriasiform acanthosis. So you can call it that, but it is not true psoriasiform hyperplasia. Now, dilated capillary loops is when you have these in the papillary dermis. If you see a prominent papillae with dilated capillaries inside, you call that dilated capillary loops. Here, the capillaries are prominent throughout the dermis. Okay, so there is no prominent dilated capillary loops. Now, what in fact is more prominent is this dense fibrosis in the dermis. Now, what is the difference between sclerosis and fibrosis? It's a very subtle difference. When we say sclerosis, we are referring to the collagen becoming more homogeneous. Here the collagen fibers, individual fibers are maintaining the texture because there is no inflammation or there is no destruction of the collagen. In say something like lichen sclerosis, the collagen is destroyed and becomes homogeneous, and that's where we call it sclerosis. Here it is more of a fibrosis rather than sclerosis because individual collagen fibers retain their shape though they're quite markedly thickened, and this is simply because of chronic scratching and because of the inflammation there in the dermis. There are dilated capillary loops, which is reactive vascular proliferation, and then the collagen also becomes slightly thickened. Now if you look close enough, there is indeed a colloid body here. There is a small colloid body here where there is some vascular interface change. However, again, remember, just because you're seeing one colloid body and you're seeing pigment incontinence certainly, but pigment incontinence again is non-specific. Whenever there is chronic damage to the epidermis, the epidermal keratinocytes do fall down into the dermis, and these keratinocytes, because they have some melanin in them, this melanin, because it cannot get absorbed immediately, it stays in the papillary dermis as melanin incontinence and becomes melalophagus in some places. Okay. So compact hyperkeratosis is present. There is no loss of polarity of keratinocytes. If there is loss of polarity, we mean malignancy. It's not a malignancy. There is wedge-shaped hypergranulosis. Lichenoid interface dermatitis is indeed present, though very focal. It is indeed present. It is not. So I just asked you whether there is lichenoid interface dermatitis or not. I didn't ask you whether this is a lichenoid interface dermatitis. Yes, there is a focal interface of lichenoid dermatitis which is present. Papillary dermal sclerosis is absent. Pigment incontinence present. Dilated capillary loops are absent. It is not just papillary dermis. In fact, the dilated capillary loops are present throughout the dermis. Suprapapillary plate thinning is absent. Suprapapillary plate thinning refers to, you see here, this is a papilla. Suprapapillary plate is quite thick. It's not thinned out. In psoriasis, what happens is goes way high up and the suprapapillary plate is thinned out. Okay, so there is no suprapapillary plate thinning. There are no coilocytes, and there is a colloid body. Having said that, though quite a few features here are those of lichen planus, there is wedge-shaped hypergranulosis. There is, even if you look close enough, some sawtoothing of the retiridges, but this is not true sawtoothing. Sawtoothing refers to the retiridges being eaten away by the lichenoid infiltrate. Here the infiltrate is really sparse. It's just distributed in the dermis. It's not in the interface. If in this context you are seeing a dense lichenoid infiltrate throughout the papillary dermis, then you may call this lichen planus. In the absence of this, and given the clinical, this is simply a case of lichen simplex chronicus with focal interface change. Pigment incontinence is present. There is a colloid body, but on balance, and this is why you need CPC, this is why you need clinical pathological correlation. On balance, this is a case of lichen simplex chronicus. This is not lichen planus. I'm sorry this was confusing, but I intended this to be confusing for you so that you understand the importance of clinical pathological correlation, how it is very essential for a dermatopathologist to have some clinical knowledge and for the clinician to have dermatopathology knowledge to arrive at a consensus diagnosis. Thank you.